This lecture is on the symptom management in cancer patients following treatment. Here I use the word symptom loosely. In other words, when I say symptoms, I may mean signs and symptoms. Learning outcomes. By the end of this lecture, you should be able to recognize and know how to manage the following: chemotherapy-induced nausea and vomiting, immunosuppression or pancytopenia, namely anemia, leukopenia, and thrombocytopenia. Two treatment modalities, namely radiation and chemotherapy, target rapidly dividing cells. Unfortunately, chemo and radiation affects not just cancer cells, but other normally rapidly dividing cells. And these include hair follicles, cells in our digestive tract, and bone marrow. And so, many cancer patients will experience alopecia, nausea and vomiting, and bone marrow suppression, which leads to immunosuppression or pancytopenia. In this lecture, I will be discussing two of the most common and dreaded clinical manifestations of cancer: nausea/vomiting and immunosuppression. Chemotherapy-induced nausea and vomiting. Note this general principle. Regardless of which drug or drugs are being used to prevent or reduce CINV, they are most effective when used aggressively and on a scheduled basis. Drug therapy for chemotherapy-induced nausea and vomiting works best when given before nausea and vomiting goes out of control. Thus, the nursing priority is to ensure that drugs are given before chemotherapy. There are three categories of chemotherapy-induced nausea and vomiting. There's acute, delayed, and anticipatory. Each of these has an equivalent pharmacological treatment. Ondansetron and dexamethasone for acute onset, which is nausea and vomiting that occurs within 24 hours of chemotherapy, and ondansetron and dexamethasone for delayed onset, which is nausea and vomiting after 24 hours to several days after chemo. And there's anticipatory nausea and vomiting, which may be triggered by sight, smell, or anxiety, or inadequate management of chemotherapy-induced nausea and vomiting. And the medication for that are benzodiazepines. An example would be lorazepam or Ativan. Please know these drugs and their different uses in CINV or chemotherapy-induced nausea and vomiting. Apart from chemotherapy-induced nausea and vomiting, cancer patients can also experience bone marrow suppression leading to immunosuppression or pancytopenia, which means that red blood cells decrease, white blood cells decrease, and platelet count also decreases. Please know these values by heart. Hemoglobin is between 12 to 18 grams per deciliter. Hematocrit is between 35 to 52%. White blood cells is between 4,500 to 11,000 per cubic millimeter or milliliter, and neutrophil count is between 1,500 and 8,000, and platelet count is between 150,000 and 450,000. And for each of these, you will have a nursing diagnosis. So for anemia or low red blood cells, you will have fatigue. For decreased white blood cells, you will have risk for infection. And for thrombocytopenia, you have risk for bleeding. So how do we manage immunosuppression in cancer patients? We use hematopoietic growth factors or colony-stimulating factors. Please know these drugs. So for low RBC, there's erythropoietin with brand names such as Epogen and Procrit. With lowered white blood cells or neutropenia, we have granulocyte stimulating factors such as filgrastim and the granulocyte macrophage colony stimulating factor, which is sargramostim. And for thrombocytopenia, which is lowered platelets, we have thrombopoietin or romiplastim and oprelvecin. So those are the hematopoietic growth factors or colony stimulating factors, which is the pharmacological management of pancytopenia. Please know by heart the lab values and the drugs for nausea, vomiting, and the drugs for immunosuppression. This ends my lecture. Thank you.